Hi, folks. This is Dr. Rob Cywes here. And, one of the things that we all do, we spend time on the internet, we spend time on social media, and we listen to all these people offering advice and offering information and guidance on the internet. And sometimes they are very plausible and believable because of their enigmatic personality. And the question is, should we believe what they're spouting, and what is their backstory? What legitimacy do they have? And I've thought a lot about some of the gum flappers, I call them, on the internet, people spouting off, I did this and therefore you must do this, or I've got this little piece of paper in my hand that I did a weekend course. And it just boggles my mind how fastidiously a lot of my patients follow the wrong advice from the wrong people who just don't understand what's going on. And at the same time, there's a tremendous amount of good information out there. And then today, as I was taping, getting ready to tape some of these videos today with my friend James, who is our videographer and IT guy, I walked into my office. And as I walked into my office complex, and if ever you come to visit me as a patient or step into our office, one of the first things that you'll see is what's behind me over here. And James will get a broader view of it. And it really is just a glimpse into my professional history, into my credentials, into who I am. And I thought, as part of legitimacy, let me at least give you my backstory, give you who I am from a professional and a personal perspective, and give you the good, the bad, and the ugly. And as you can see back here, there are a couple of my degrees. And the funny thing in the statement that I often make is that I could probably wallpaper this entire room that I'm sitting in right now with all the degrees and certificates that I've accomplished. And you know what? It's all just dead trees. We have all these certificates, and I've got them all. I've got the highest degrees behind me. I'll talk about those. But really what it comes down to is my experience in the field based upon that knowledge, based upon that information. So my backstory is that I grew up in South Africa. My father was a pediatric surgeon, incredibly accomplished, world-renowned horticulturalist and pediatric surgeon. I mean, just way up there iconically as a revered human being in the practice of what he did for a living, and crossed over also into the horticulture and what he loved to do as his passion, growing roses, growing dahlias, growing orchids, and then eventually growing daisies. That's what he did for fun and pleasure. I'm his son. And the interesting thing is that as accomplished as he was, and I love him to bits, he passed away a year and a half ago, he had no clue, no idea, like all parents. No clue, no idea how to raise a child. And he did the best he could, but I am a product of how he raised that child. And one of the first things that was important to him is accomplishment. And I wanted to please him, and according to that, the easiest default option was to go to medical school. And in South Africa, I went to a phenomenal medical school. Tim Noakes, for example, one of his first, I think it was the second year he ever taught physiology, was my physiology professor. We had exposure to things at medical school that very, very few physicians world over get exposed to. I mean, the education, the training, the way of thinking, asking why, and understanding physiology and anatomy and pathophysiology, that was my foundation of medical thinking and medical training at medical school. And in the British system, we actually went to medical school for 6 years, doing the basic sciences and then slowly applying that in the clinical setting. Unlike medical students in this country, you only go to school for 4 years. And my personal belief is that 4 years is too little to understand the art and the science of medical practice. But that's just my 2 cents worth. Nevertheless, became a medical doctor, trained in South Africa, and then with the political landscape the way it was, I left the country and I came over to the US. And my father was a pediatric surgeon, and the default option was to go into pediatric surgery. But in order to do that, there's a very, very high standard, and I had to redo my general surgery and redo my some of my medical training. So I started out in Columbus, Ohio. As you can see, not a Buckeye, not a Buckeye, but loved the Buckeyes at first. Learned to love football because I was a rugby player. Actually broke my leg playing rugby in Columbus, but spent some time at Columbus Children's Hospital, and then for visa reasons, moved to Canada. And I spent almost a decade, 7 or 8 years in Toronto, which I absolutely love. I love the Canadian people. And in Toronto, I did my general surgery. So you'll see back here, at least my American boards of general surgery, but I hold the same in Canada. So became a general surgeon, but during that time also, as you'll see on the back there, I did my Ph.D. Yep. So if you look at bits of paper on the wall, I got a Ph.D. I'm board certified in general surgery. My medical degree is back there. So I've got the medical degree. I've got the boards in general surgery. I've got the Ph.D. And then following that, I went down to Michigan, the second Canadian graduate to actually make it into a US program for pediatric surgery at that time. And the University of Michigan was a phenomenal pediatric surgery training, and I became a pediatric surgeon. So what the hell am I doing in the carbohydrate addiction space? Well, what's interesting is that my imagination was always to be a pediatric liver specialist, a pediatric transplant surgeon. And I went down that pathway, and as such, I entered the laboratory, the guy called Steven Strasberg, Gary Levy, Paul Gregg in Toronto, and we studied the liver and the liver during transplantation. And the thought process then was that the liver may or may not work very well, depending on how much sugar it has available to itself as it transitions from a donor through the icebox into the recipient. And some livers weren't working well, and we believed, because obviously sugar is so important, sugar is the fuel of the human body. That was the conventional understanding in 1990. So we developed a study where we looked at two things. We looked at sugar as a substrate for the liver, and we wanted to determine if the level of sugar in the liver correlated with survivability of that liver and function of that liver in the recipient. Because a lot of these livers at that time underwent something called PNF, primary non-function. They never functioned. And the question was that related to sugar? The second thing that we were looking at in the laboratory, so my master's thesis was about correlating sugar in the liver with outcome. And we used a rat model, we used a cellular model, a rat model, a pig model, and a human model. And I'll come back to that in a second. Then other folks in our laboratory, in our liver transplant laboratory, were looking at something else that we noticed in livers that performed very poorly. We looked at the inflammatory markers because we noticed that there was a tremendous vascular inflammatory reaction when you did biopsies or autopsies on livers that had failed early on in the recipient. Those primary non-functioning livers, the blood vessels were clogged with these clots, these blood clots of highly active inflammation in the liver. Okay, so we've got inflammation, we've got this belief that there's not enough sugar in these livers. How do we put more sugar in these livers? And one of the things that we were also working on in the laboratory was the concept of fatty liver, because we were starting to understand that the more fatty the donor liver was, the less likely it was to function properly. And more we were seeing donors with fatty livers. And remember, these are all people that died traumatically, most commonly after motor vehicle accidents. And the donors were all on steroids, they were on huge drugs, and they were getting infusions of sugar into the liver, because clearly sugar is so important. So the donors were being fed the sugar, and a lot of them had fatty livers. But at that time, we had no concept that a fatty liver was anything other than the disgusting fat that all Americans and Canadians were stuffing their faces with. and that the fatty liver was because we were eating so much fat. So several misconceptions. And so in my master's thesis, I became extremely good at very, very rapidly glycogenating the liver. So we would do this stain called a PAS stain, which is a stain for glycogen in the liver, and we take a starved, a fasted liver, and within 3 hours, using what's called an insulin glucose clamp, infusing glucose and infusing insulin so that the insulin would just shove huge amounts of sugar into those cells, we could massively and very quickly glycogenate those livers. Now, what we found is when we then transplanted livers that were variably glycogenated into pigs and into other rats, became very good at rat liver transplants, pediatric surgery, and pig liver transplants. So what we found is that those livers, at first, when they were completely empty of glycogen, performed okay, but struggled a little bit. Performed okay, but struggled a little bit. There was a little bit of damage and necrosis or cellular death of some of the hepatocytes after they were transplanted. And then in a dose-dependent curve, as we increased the glycogen in those livers from zero going forward, or not zero, but extremely low, almost unmeasurable, going forward, as we glycogenated those livers, their function and the quality of the cells in terms of death, in terms of structural integrity, improved for a short-lived period. But then, as we got more glycogen into the livers, as we forced more sugar into those livers, it fell off like falling off a cliff. And the livers performed terribly. They wouldn't function, they died, and the livers did not function. So the paradox is, our hypothesis is that the more sugar in the liver, the better they function. But after a very short amount of improvement, and far less than we predicted, there was this crash. And when we did biopsies and analyzed the pathology of those livers, what we found was very, very early on in those livers, the ones that died early because of the massive amounts of glycogen, the more glycogen they had in the liver, the more cellular inflammation there was in the sinusoids and the blood vessels and the capillaries, sinusoids are the capillaries in the livers. The more plugged they were, the more the inflammatory reaction was. But of course, that was exactly the opposite of our hypothesis. So what do good scientists supported by grants do? And this is important to understand because this is not a little bit of mirth here, but mostly reality. What good scientists do when they're totally locked into and boxed into their hypothesis, and they've got grant funding and they're working with a group that believes intensely and their whole world is about the value of sugar. We removed a variety of different data points from our data because we found reasons why those animals and those humans should be outliers. So we messed with our data to prove our hypothesis. And you know how commonly that happens? Almost all of the big nutrition studies and almost all of the big statin studies and the studies that are there to show that fat is bad, sugar is good, almost all of them have used the same methodology that I used in the laboratory. Because I could not fathom, our team could not fathom that what we were saying was actually wrong. It's impossible to think that sugar could possibly be bad. And we were actually just working on a technique to rapidly increase the amount of sugar in these livers. Because clearly fatty livers were bad and fat was bad. But what we did show, and here's what I've done, I've gone back and re-looked at some of my data. I haven't published it, but because I don't have sufficient collaborative data on this, and I think it would be a great study to do again. But I look back at my own personal notebooks and my own personal data and some of my own slides, and when we put everything into the same box, In other words, we didn't create those outliers that we removed from the box to tell the stories, like Ansel Adams did with the 7-country study that proved that fat was so bad for us with cardiovascular disease. When we did that, we saw a couple of things. We saw, number one, there was a dose-response inflammation in the sinusoids of the liver. And the dose-response curve was a profound inflammatory change to the endothelial cells, the cells that line the blood vessels, as well as clumping of platelets and introduction of fibrin clots, platelets, and then white cells. So this massive, very rapid inflammatory cascade that just plugged up the blood vessels and prevented oxygen and nutrients from feeding the liver, and therefore feeding the rest of the body. So we saw this catastrophic inflammatory cascade in the livers. And we also saw the evolution, the development of foam cells in the hepatocytes. Foam cells are cells lined with or loaded with a lot of fat. So in reality, what these livers were doing, and so impressive how good the hepatocytes work, they were taking the sugar that we were feeding into them, and the sugar was becoming toxic, and the livers were just cranking out and desperately trying to turn that sugar into fat. And that happens inside the hepatocytes. De novo lipogenesis, the conversion of sugar to fat. And the problem is that fat couldn't be gotten out of the cells quick enough because the rate limiting step is VLDL. So we couldn't get the fat out of the liver cells, so the fat was building up. So we had the glycogen plus these fat droplets. And when I go back and look at those studies, that's what I'm seeing. And we see the damage, the inflammatory activation of the endothelial cells. We see these knots, these clogs of fibrin clots, of platelets that get activated, and then the leukocytes going in there. And all triggered by the infusion of sugar. Because when we infused fat, the TPN, the lipid from fat. And yes, folks, it wasn't saturated fat. It was polyunsaturated fat that we were soy-based fat that we were infusing into the livers. And when we infused different types of amino acids, glutamine, for example, we thought would be an advantage. We saw none of this. We did not see this injury with protein or with fat. The injury was caused by sugar, which was the very molecule that we thought was necessary to dumb that down. And folks, what I've just described is a disease called diabetes. That is diabetes, where chronically elevated blood sugar levels damage the endothelial cells, cause inflammation, and that inflammation results in a clotting cascade of fibrin clot, introduction of platelets become activated. And then the white blood cells and the macrophages and the Kupffer cells, which are macrophages in the liver, get activated, and they form the inflammatory reaction that is diabetes, that kills people and causes the damage of diabetes. We proved that, we showed that in the laboratory categorically. But we disconnected the dots between sugar and that inflammatory cascade. So a separate parallel group in the laboratory was working on this inflammation, the cellular inflammation and the fibrinous inflammation that we were seeing in the livers of donors of recipients who died before the liver could begin to function. When you biopsied those livers, we saw this inflammatory reaction, and that was the cause of these people dying. But we didn't make a correlate with the nutrition. We looked at this inflammatory cascade, and we studied the inflammatory cascade because if you could block, the theory was, if you could block inflammation in the donor livers, that cascade, you would have a healthy liver down the road. We had no idea, and we chose not to know what the cause was. In fact, we actually believed it was fat and cholesterol because these were fatty livers. It must be the fat we're eating that is causing the fatty livers that have the highest cascade of inflammation. So I then went on, after we, very nice kumbaya, yes, you can glycogenate the liver, yes, it's better. We then went on in my PhD, I said, okay, we're seeing these platelets becoming activated. Pierre Clavier and another a laboratory friend of mine, who's now a bigwig in Switzerland in the transplant and the hepatology world, Pierre and I were PhD classmates. And peer look at leukocytes with a woman by the name of Claire Holloway. They looked at the white blood cell activation, and I looked at platelets. And we became extremely good at blocking platelet activation using thromboxane A2 inhibitors. Big word. What's thromboxane? Aspirin, prostaglandin, Viagra. Yeah. We use those to block platelet activation. Those things work pretty darn well. We also looked at some of the early factor blockers. For example, Eliquis, that medication that we use for atrial fibrillation and to help people to reduce blood clots, a factor 10A inhibitor. We looked at inhibiting the cascade of clotting. We looked at calcium, we looked at some of the factors. I did some work later on with CPS1 deficiency in the clotting cascade. My PhD was about platelet activation and blocking platelet activation to make those livers better. And we became very good at doing that, but we really couldn't save those fatty livers. Why? Because our hypothesis was wrong. Our hypothesis was that lipid caused the damage, that fat caused the damage, and we conveniently ignored sugar. Just to tell you the depths of how important it was to ignore sugar, one of the members of my PhD committee was a guy called Dr. David Jenkins. Brilliant man. But David Jenkins, in 1981, wrote the seminal paper about the glycemic index for the treatment of diabetes. That's how deep our belief is that carbohydrates are critically important in our diet as nutrients for our cells. So from that background, how the hell could you say that carbohydrates are bad? And the glycemic index right now is the biggest enemy of every diabetic, in my opinion. And yet David Jenkins, brilliant man, bought into that and got us to buy into carbohydrate dynamics as being good and fat being bad. And it was only afterwards when I took my laboratory information to the clinical setting and realized, wow, what I'm looking at in the laboratory and what I lied about and misrepresented in my laboratory findings is actually the truth if I look at it through a different lens. And what was that lens? Well, I went on to this wonderful place, what I consider my alma mater in the US, University of Michigan, Mott Children's Hospital, and I did my PhD. And I was doing a lot of laparoscopic work, and once I left Michigan, my first job in the late 1990s was as an assistant professor of pediatric surgery at Vanderbilt University in Nashville, Tennessee. And I loved laparoscopy. I was the laparoscopic guy. It was just starting to happen. Everybody else was still cutting people open to do surgery. So my colleagues were pretty smart. You know how difficult it is to operate on fat kids? Fat kids have ridiculously high complication rates. When you cut them open to do surgery on them, just the wound itself has a 30% incidence of infections, of breakdowns, of hernias. It's awful. So this new skill called laparoscopy, which are tiny little keyholes, tiny little holes, and when you can operate on a fat kid laparoscopically to do whatever it is you need to do in their belly or their chest, it just makes that wound healing issue go away. So what happened is all my colleagues that were still doing open surgery referred all the fat kids to me. So I would be taking out fat kids' gallbladders. Now, kids should never have their gallbladders removed for cholesterol gallstones, but we're seeing more and more of that. We're seeing polycystic ovarian syndrome in these young adolescents. Girls shouldn't have polycystic ovarian syndrome, PCOS, with these big cysts that twist and cause torsions. So we started seeing more and more adult obesity-related diseases that required surgery. Okay? So I got referred all these kids. And there was one young man, a 13-year-old boy, if I remember correctly, one of my early patients, who had a horrible attack of gallstones. And he was an African-American kid. So I said, okay, he had a family history of sickle cell. So I said, okay, this is cool. This is just a pediatric sickle cell problem. And it's very common for us to take gallbladders out of patients who have sickle cell disease because they get hemoglobin gets secreted into the gallbladder and they get these black pigment stones that cause awful inflammation of the gallbladder. Fairly common in kids. So I thought, okay, that's what it is. And when I got in there, I realized, no. This is adult gallstone disease. This is cholesterol gallstone disease. Why the hell does a 13-year-old have cholesterol gallstones? Well, kid's 400 pounds. Kid's 5'6", 5'7", 400 pounds, as wide as he is tall. And I realized, my God, here I am taking out cholesterol gallstones out of this kid. And yet, I do not have the capacity to help this young man with all this fat. And he must be eating extraordinary amounts of fat to be this fat. Maybe he's got Prader-Willi syndrome, but he doesn't have red hair. Okay, so post-operatively, I'm in the kid's room and chatting with him, and he's starting to eat. He's feeling much better. What's he eating? Big Mac, waffles, fries. There's chocolates and candy and bags of chips all over the place. Drinking Dr. Pepper. So I said to myself, if this is what he's eating now, and this is probably what he's eating routinely, just by eyeballing the food, over 90% of the caloric content of what was in that kid's room wasn't fat. Yes, there was fat present. But a potato chip that's been fried in fat is not about the fat. 80-90% of that energy is carbohydrate. So how the hell is it possible that a kid who's eating 80-90% of their calories is carbohydrates, and talking to the parents, who are also very, very large because it was a permissive family, they're all eating sugar and starch. They're all eating sugar and starch. How the hell is it possible that something they're hardly eating, which is saturated fat, which was so bad for us, how the hell is it possible that something that these kids are not eating makes them 400 pounds? And suddenly, I remember I was at home that night, it's about 2 or 3 o'clock in the morning, and I had that eureka moment where I sat bolt upright in bed, and I said, holy shit. And the dots just came together. My Ph.D. and this kid. Now, if you look at that, that's not a Mercedes sign, so there's got to be one other component. And there was another component, which I haven't talked about yet. Folks, at the University of Michigan, from the Children's Hospital, this is in the old Children's Hospital, from the Children's Hospital down to the ER, to the Children's ER, there was a walk, and we worked 120 hours a week. We were in the hospital every other night, on call. It was a wonderful, wonderful experience that I wouldn't trade for anything. But we worked our asses off. There are 168 hours in the work week, in a week. And I have intimate knowledge of every one of them because I've worked them all. But we had free access. So between the OR and the Children's Hospital and the ER at the University of Michigan, there was this long corridor that you'd walk down, go down to the trauma unit and to where the kids were. And guess what, folks? Right in the middle, Wendy's, open 24/7. And you know what they gave us as fellows? They gave us a card that gave us free access to Wendy's. Free access to Wendy's, okay? When we're exhausted, when we're tired, when we're stressed, when we're working our asses off, when we don't have time to eat, free access to Wendy's. And let me roll this back. When I was in Toronto, I worked at Mount Sinai Hospital. And in the big lobby of Mount Sinai Hospital in Toronto, I loved Mount Sinai Hospital. My lab was upstairs, and the vivarium where the rats and the pigs were downstairs. So multiple times a day, we would walk down from our laboratory into the lobby. And what was in the lobby? Second Cup. Second Cup was a coffee place, but it sold muffins. And it sold bran muffins. And they were these massive bran muffins. And by the way, that Second Cup, at that time, in the early 90s, in the tiny little stall, it was like a little wagon, was the second largest producer for the Second Cup chain in the entirety of Canada by volume. So, and I think I made that happen. So going back and forth from the lab to the vivarium, back and forth all the time, every time I went by, stop, get my cup of coffee, get my bran muffin. And long story short, between the Second Cup in Toronto and then Wendy's at Michigan, I ballooned up to be 297 pounds.